Thank you for joining us for today's webinar. Myself, Dr. Abhijit Malvi. I am medical advisor at Intas Pharmaceutical Limited. Being a science-driven pharmaceutical company, Intas is always at the forefront in providing educational platforms. During this time of social distancing, webinar is a best platform for getting knowledge from the experts. Maternal fetal medicine is a subspecialty began in 1960s with the introduction of technological advances like ultrasound and fetoscopy. And today, maternal fetal medicine is one of the most rapidly evolving fields of medicine. The topic for today's webinar is understanding dual, triple, quadruple markers and NIPT during ANC in 2020. And the expert with us is Dr. Prashant Acharya. Dr. Prashant Acharya is a consultant in fetal medicine and high-risk obstetric care at Advanced Center for Fetal Medicine at Ahmedabad. He is honorary sonologist and fetal medicine consultant at Seth Chennai Maternity and Vadilal Sarabhai General Hospital, KM School of Postgraduate Medicine and Research, Ahmedabad. He is International Society of Ultrasound in Obstetric and Gynecology, that is ICOG board member, trustee and director 2015 to 2019, first Asian to be honored. He is ICOG ambassador to South Asia and India. He is executive committee member and permanent trustee of Indian Society of Ultrasound in OBGYN since inception. He is invited as a faculty at national and international conferences and CME on more than 450 occasions till date and has authored many books and publications. His research and clinical interests include fetal imaging, fetal growth and Doppler, fetal interventions, fetal cardiology, and in particular fetal anemia. Now, without further delay, I will turn the time over to our expert for the webinar, Dr. Prashant Acharya, sir. Over to you, sir.
Hi, good afternoon. This is Dr. Prashant Acharya, and what we are going to discuss today in the afternoon is what is dual marker, triple marker, quadruple marker, NIPT during our antenatal care, which we provide in 2020. Today is 2020, and the concepts are totally different. What we used to think about before years together, and now the things are really very different. So today is 2020, and in 2020, because of the technology updates, the fetal medicine or fetal imaging and its therapy and its diagnosis has reached to a different level. And this is possible only because of some brilliant imaging by 2D, 3D, 4D, because of the evolution of ultrasound technique. And this evolution of the technology has given us a lot of scope by which we can diagnose so many of the fetal malformations that includes fetal aneuploidy. Today, we are going to concentrate on fetal aneuploidy. And the moment it comes to fetal aneuploidy, our first perception is about Down syndrome, that is trisomy 21. Now, do you consider this fetus, the child which is shown here, it's a typically Down syndrome baby, and is it an enemy of us? Probably no. If I can find it out, a fetus having trisomy 21 in utero, then do I consider that I'm a winner? And if I don't diagnose trisomy 21 and say for some reason I have missed one trisomy 21, and if a baby delivers with trisomy 21, is it my defeat? Every one of us will have some different kind of logic and different kind of idea on my equation, which I have shown it to you right now. But definitely, yes, my job as a consultant is to tell the couple that the fetus inside the uterus is having Down syndrome. Now it will be their choice whether if they want to continue or if they do not want to continue. My job is to diagnose the baby's chromosomal malformation, and that is the reason why in the today's time we look for so many ultrasound features, so many biochemical markers, self-repeated DNA and whatnot. My target is to diagnose. It is about diagnosing. It is not about terminating. It is about diagnosing a trisomy 21 in utero and give the couple the choice. So now this is one very good and well-known picture. Today's antenatal care. We ask a lady to come down once in a 3-month first, then every month till the end of the 6th month, and then we call her every 15 days. And in the last month, we ask her to come every week. So if you draw a pyramid, this is going to be like this. But at Paras Hospital, Ahmedabad, we have formulated a new system because this is not working well. And this is what Kipros has suggested, that one visit at 12 week, one visit at 22 week, and one visit at 39th week. This is by a specialist care has to be given. But what we feel that in India, still the system has to be one visit at 3 months, the next visit should be at 5 months, then next visit has to be at 7 months, and then one last has to be 9th month. That is by doing ultrasound and detailed ultrasound for decision making. 3 months, 3, 5, 7, and 9. If we perform these 4 ultrasound together, what we call it is a tube of pregnancy care, not pyramid of pregnancy care, but this is tube of pregnancy care 3, 5, 7, and 9. This is a concept which Paras Hospital, Ahmedabad, we have floated across, and we find quite a lot of good satisfactory result apart from because of this tube care. Now, we have also formulated a rule of 2, and this is what a rule of 2 is for first trimester. Everything falls in a rule of 2. The same thing is a second trimester, also a targeted anomaly scan, that also we follow the rule of 2. But in both of the situation, there are some of the dual markers or some of the NIPT, some role of alpha fetoprotein PLGF in first trimester, and in second trimester role of NIPT and quadruple marker is there, and that is what we are going to discuss today in the afternoon. To understand the aneuploidy, we need to understand the basic statistics of the medical statistics. Now, because to know the medical statistics, there are few terms which we need to understand: mean, mode, median, standard deviation, centile, p-value, MOM, likelihood ratios, positive, negative, confidence interval, positive predictive value, and negative predictive value. Now, let us understand. If you want to understand aneuploidy, specificity, sensitivity, positive predictive value, negative predictive value, likelihood ratio, detection rate, and MOM, that is multiple of median. These 4 and 3, 7 basic terminology, we need to understand what each of them gives you the information, and we need to understand all of them. So let us go for those things. Mean, you understand, you sum of all the figure and divided by the total number, you get a mean. So we have taken as a example one group 5, 6, 9, 9, 10, 11, 12, and 18. Here the mean is going to be 10. The same thing is median. It is not necessary that mean, mode, and median are going to be the same figure in the same group of figures. So here the median, it's a middle value of the entire from the first to the last. The median value, that is 9.5, and mode is most common occurring value, that is 9 here. So it is 9, 9.5, 10. So that does not mean that mean, mode, and median is going to give you the same figure. It's all different and has got its own different kind of value in statistics. Let us understand the normal distribution. The normal distribution is a symmetric kind of distribution. So if you fold it like a paper from the middle, if you open it, it is going to give you exactly the same 2 halves, and they are going to match with each other, and it will have a uni-model peak, single peak. So we'll have a single peak. Exactly, the peak is going to give you the 50th centile, that the highest point, and the last 5% and the first 5% we consider from that is going to be the 5th centile, and last is going to be considered as a 95th centile. So this is what a normal distribution is, and from that let us understand what is standard deviation. The standard deviation is most commonly reported measure of variability, or probably the spread. The probability that normal distributed quantity will be within a specified multiple of the standard deviation of its mean is the same for all normal distributions. There are a few simple steps. First, calculate the mean, and next is the sum of squared deviations of each to mean is divided by 1 less than the sample size rather than the sample size itself. It looks complicated. Let us make it simple. So basically, what does this standard deviation convey to us? When a data is from 50th centile, when we consider one standard deviation on plus and the minus side, this is going to cover approximately 68% of the data overall. So from median, 1.34% on right side and 34% on the left side, one standard deviation is going to cover. If you put it across 2 standard deviation, approximately 95% of the data which is going to lie within these 2 standard deviations. And if you call it as a 3 standard deviation, 99.7% of the data will lie in these 3 standard deviations. So that's the value of understanding a standard deviation. We consider 95, if at all a data a reading which falls in 95% of the data with that is 2 standard deviation, they all we consider as a normal stuff. So that is the reason that we always go for plus or minus 2 standard deviation. That means the data will lie within that 95% of the data which we consider as a normal. Now let us take one example how it is going to be calculated. They are the values, they are the equations. Let us skip those equations rather than making it ourselves more complicated. So let us take one group, the 5, 6, 9, 13, and 7. If I consider mean, if I make it a total divided by 5, this is coming to 50. Now, and 50 divided by 5, so mean is 10. Now the deviations are, these 5 has to be 5 minus 10, 6 minus 10, 9 minus 10, 13 minus 10, and 17 minus 10. So overall value is going to be minus 5, minus 4, minus 1, 3, and 7. Now I have to square them. So minus 5 multiplied by minus 5 will become 25. Minus 4 is 16. 1 is 1. 3 raised to 3 is 9. And 7 raised to 7 is 49. Now what I have to do is I have to sum up all of them. So that is 25, 16, 1, 9, and 49. It has to be divided by, because 5 was number, 5 figures are there, 5 minus 1. So 100 minus 4, this total is 100. 5 minus 1 is 4. So this is 100 minus 4, that is 25. If I square root this 25 is going to come as a 5. So 5 is a standard deviation factor for these group of figures. The same way, if I take it 2 standard deviation plus or minus, that means from the middle figure, the mean was 10. If I take it 2 or on 2 times 5, 10 on both the sides, this is going to cover almost 95% of normal data. That's how the standard deviation is calculated. Now multiple of median. It's a simple English. Multiple of median. Median means 50th centile. Any value which is deviated from median, that multiple times is multiple of median. Say for example, the moment I put it that this has got, like say for example, in Down syndrome, we call it as a beta HCG is going to rise to 2 mom. That means the median, if I take the median value, it has to be double the median value. If the value is double the median, that is 2 MOM. If I say it is 0.8 MOM, that means it is 20% less than median value. That is 0.8, because 100 is median, 80 is 20% less. So if the value is 20% less, that is considered as 0.8 MOM. The meaning is simple. The moment it goes, if I say 0.2 MOM, it says that it is only 20% of the normal value. So that is 0.2 mom. So if the mom value goes up, that means to that specific gestation, that median value is going that much multiple time above the median range. If I say it is below 1, if I say it is 0.5, that means it is half the value of the median at that particular gestation. It is independent of the gestation, and that is the reason the independent of gestation and independent of the value number. So that is the reason the mom gives you clear idea how much deviation from normal value is from median. So that's the importance of mom value. Lot many much more clear understanding about how the biochemical markers are to be read, because all values are going to be not absolute value to be taken into consideration, but it is a mom value which has to be taken into consideration. Now, one another important aspect is marker and its likelihood ratios. Now, unless we understand the likelihood ratio, we cannot understand what exactly and how these markers are going to be should be taken into consideration. Let us take one example. Say, for example, at my center, if I conduct a study, I want to evaluate the role of nuchal fold thickness if it is more than 6 millimeter and its relation to the trisomy 21. And if I evaluate X number of patients, and in that case, there are going to be few patients which will have more than 6 millimeter of nuchal. Out of that, few will have Down syndrome, few may not have Down syndrome. And those who has got less than 6 millimeter nuchal fold, majority of them will not have Down syndrome, but few may come out with a Down syndrome. And because there are 4 group of the patient, and that is how we put it into this, and we try and analyze what exactly this is. So we have taken one, say, group of 2, 5, 7, 9 group of patients, and we have evaluated the same nuchal fold thickness, and we could find out that there are 731 fetuses which had more than 6 millimeter of nuchal and which had Down syndrome. But there are 270 patients who had more than 6 millimeter nuchal, but they did not had Down syndrome. The same way, although 6 millimeter the nuchal was less than 6, 78% had Down syndrome, but those who had less than 6 millimeter, 1500 patients did not have Down syndrome. So out of 2579, I know that there are 1770 fetus who do not have Down syndrome. There are 809 fetuses who had Down syndrome out of 2579. But here, more than 6 millimeter, I had almost 1000 patients, and less than 6 millimeter, I had almost 1578. Now, how to analyze this figure and how to put into the ratios, and how to have get these figures more kind of understanding about sensitivity and specificity and all kind of stuff. A sensitivity is to be calculated. This is just I'm explaining for understanding. So sensitivity means the sign was present in that many patients in the number of positive cases. Here 731 cases, the sign was positive and there was disease out of total 809. So it conveys you one thing, that out of 800 total 809 Down syndrome, there were 731 Down syndrome. So it has capacity of diagnosing 90%. 731 divided by 809, that is 90%. So 90%, the nuchal fold thickness has sensitivity. It can detect 90%. Now, if this is how, if at all the sign is absent, say the nuchal fold is less than 6 millimeter, that is out of 1770, 1500 has normal nuchal and disease was absent. So this is true negative, this is true positive. So 1500 divided by 1770, that is 85%. So if disease is, the sign is absent, disease is going to be absent in 85%. And here sign is present, disease is present, that is 90%. So now these two figures, they will play crucial role in evaluation or giving you the likelihood ratio, positive likelihood ratio or negative likelihood ratio. A positive likelihood ratio means the sensitivity divided by 100 minus specificity. So here sensitivity is 90 divided by 100 minus 85. It comes to 90 divided by 5, and the figure, magical figure, is 6. So the meaning is, if the nuchal fold thickness is more than 6 millimeter, the chances of disease goes, or trisomy 21 goes up by 6 times. The same way, negative likelihood ratio is to be calculated by 100 minus sensitivity divided by specificity. So this is 100 minus 90 divided by 85. So this is 10 divided by 85 is 0.12. The meaning is, if the nuchal fold thickness is less than 6 millimeter, the disease is going to be absent, which is going to be present by only in 0.12 times. That is 1/10 of the possibility. The possibility reduces by almost 10 times. Here the possibility goes up by 6 times. Here it tells you the likelihood of the disease will be reduced by almost 9 to 10 times. So that is the value of likelihood ratio. In nutshell, more is the likelihood ratio, more is the chances of the disease, and more is the nuisance value. In simple language, this is a nuisance value of one soft marker present. Absent disease, that much, if smaller and smaller and smaller is the figure, less and less and less are the chances of having disease. So that's the value of understanding the positive likelihood ratio and negative likelihood ratio. Higher is the value of likelihood positive, more are the chances. Smaller is the value of negative likelihood ratio, less are the chances of having disease if that sign is present or if that sign is absent. So that is how you utilize the nuisance value of this. And the same thing, every ultrasound markers, whether it is nuchal, nasal bone, ductus venosus, tricuspid regurgitation, nuchal, or this is for the first trimester, or in the second trimester, all ultrasound markers, there are 8 ultrasound markers, everything will have its own positive and likelihood and negative likelihood ratio. The same thing is with all biochemical markers, whether it's a free beta HCG and PAPE, alpha fetoprotein, E3, inhibin A, or beta HCG, everything will have its own positive and its own negative likelihood ratio. So we need, now you have understood that more is what is likelihood ratio means, positive likelihood ratio and negative likelihood ratio is. This is in one go, it will explain you all possible outcome of the statistics which you are going to get out of that group of findings. I'm not going to discuss those things first right away, but all in all, you know that this is what we have already discussed this. Now, one specific point I would like to focus, that is false positive ratio, because every likelihood ratio will be there along with false positive ratio. The false positive ratio means it is raising false alarm. The meaning is the whatever screening test you have applied will tell you that there are chances of disease, but in fact that fetus or that disease is absent in the fetus. So meaning is simple, it raises false alarm. So more the false alarm is, more you are going to investigate that fetus or that particular pregnancy. So what we need, a test which gives you least false positive ratio. That means it should have a lowest false positive ratio, but it should have highest detection rate. So it should be able to diagnose highest number of the abnormality with the lowest chances of creating a false alarm. So whenever you choose any investigation, it should have the highest detection rate and lowest false positive rate. So if you can understand these dictum, you will be able to understand the entire aneuploidy screening very crystal clear, and they go hand in hand. If I increases the false positive ratio, this is going to increase the detection rate. If I reduce the false positive ratio, the detection is also going to be reduced. So if I want to compare two tests, it has to be compared either by fixed false positive ratio or it has to be fixed by detection ratio. So if I fix it at a false positive ratio, in the today's time, internationally, it is all said that 3% false positive ratio is acceptable. So all tests are compared at 3% false positive, and then they compare how much amount of disease which are detected by X test, Y test, or Z test. So that is how the comparison has to be. So it has to be understood, and if once you understand these things, let us go for its clinical application. Now, as an obstetrician, you are worried about these dreaded 9 complications, and today what we are going to discuss about the chromosomal defects and its implication in your this thing. And this is what we have already discussed, 3579. It's a tube care by the concept is by Paras Hospital. And aneuploidy screening normally be applied by 11 to 13 week and 20 week There is a definite role of ultrasound, biochemical markers, and cell-free DNA in 2020 in the present era. Now let us try and understand. An 11 to 13 week scan, the aneuploidy screening has its own value and its component. Now, which test is to be done, which test is to be applied? There are a lot many factors are affecting. The factors affecting is knowledge of consultant. Now, how much knowledge you have about the first trimester screening, second trimester, or NIPT, you will apply to your patient, and that's the reason I have put it that as a first. Next comes the knowledge of a sonologist. Now, if your sonologist or those who are doing scan for you, if you are doing your scan, that's perfect, far better than relying on any other. If you can do your scan, now how much amount of knowledge you have or your sonologist have? Is he or she is taking good NT? Are they valid by doing ductus venosus? Are they certified doing tricuspid regurgitation or they are not? So knowledge of the sonologist is at most important. You find a guy or a lady who is genuinely knowledgeable and can have license to evaluate all these factors. Financial condition of the couple. You know that the patient needs NIPT or cell-free DNA, but if patient doesn't have any money to spend, or the biochemical markers, patient doesn't have money, then what are you going to do? So the financial condition of the couple also plays an important role in India, because nothing is free in India, and government hospital these days are not provided. So we have to rely on that, is one of the important factor. Of course, available setup. If you are working on a small ultrasound machine, you don't have good ultrasound machine, then what are you going to do? You can't perform NT, and you can't really help your patient. So it is available setup with you. I don't blame anyone, but it is, we have to work according to the available setup what we have. So, but the factor changes, the result changes. And the last is going to be relative importance of the present pregnancy. Every pregnancy has got its own importance. I know every pregnancy is precious. That is baseline without any faith. And that has to be understood very clearly. But if a lady who has got 4 kids already playing at the home, there are chances that that lady may opt for terminating a pregnancy. I don't say she's correct, but she may. Now there is a point. If a fetus which has got post IVF conception, and they will go for every possible investigation. So let us try and understand what happens during 11 to 14 week scan. Ultrasound and biochemical markers. Review of literature says that overall incidence of the chromosomal defect is almost about 2%, which goes to 4% after IVF and 6% post ICSI. And out of that, almost 45% will have chromosomal defect. And out of these 45%, almost 64% are because of the trisomies. And out of that 64%, more than 51% are because of the trisomy 21. Now, there's a difference between trisomy 21 and other trisomies. I haven't seen any human being who is alive with the trisomy 13 or trisomy 18, because they will have lethal malformations, and those are not compatible with life. So they are, most of them, they die either in utero or they die just after the birth. But Down syndrome is a syndrome or is a chromosomal malformation where the human being or that fetus will survive, but that survival is going to be quite long, may not be very long, but long, and which is going to create a burden on the family and eventually burden on the society. So that's the reason everyone is after diagnosis of trisomy 21, and we also are. That is the reason all soft markers, all biochemical markers, and everything, NIPTs, ultrasound markers, they are primarily for diagnosis of trisomy 21. So let us understand what are the prenatal tests available for screening. There are biochemical markers and some of the NIPTs which are available. Now, what I do on my scanning, they are what is known as genetic sonogram. The genetic sonogram is an ultrasound that can modify a risk a priori of fetal aneuploidy, typically based upon the ultrasound soft marker. Two new things: risk a priori and ultrasound soft marker. Now, risk, what does these mean? Risk a priori means Every lady, whether she is young or old, has got chance to deliver a Down syndrome. Let us take example. A young lady who is 20 years old, at 12 week, there are 1068, one out of almost 1000 will have chance of delivering a Down syndrome. But as the gestation age grows, the chances decreases. From the same aged lady, 20 years old, from 1068, it reduces to almost 1 in 1500 at term, because they don't survive in utero. But as the maternal age increases from 20 to 35 and 38, the same lady will have increased the chances of delivering a Down syndrome. This is because the ova aging, there is a difference between spermatogenesis and oogenesis. The sperms which are formed is always after ejaculation. They are in last 90, or somebody says 120 days of ejaculation. Whereas the ova which are formed when that lady was in her mother's womb. If a 20-year-old lady, still her ova is 21-year-old. So that's the reason there are chances of the cell division which may be at problem. As the age increases, the ova becomes that old. At the age of 35, that ova is almost 36 years, and that is the reason there are 1 in 250 chances of having the Down syndrome. Non-dissection is having problem. The soft marker is some ultrasound findings which are considered to be as a variant of normal, but they are not worthy because they also increase the risk of underlying fetal aneuploidy. So that finding is actually normal, but because of that finding, the chances of underlying aneuploidy is high, and that is the reason you ask for those kind of we consider them as likelihood, the chances of aneuploidy goes up. Right now, as far as Down syndrome goes, the Lingrodon has found, and Kipros has tried to find it out right from the ultrasound, from in utero, right from 3 months, skin too large for the body, flat face in the small nose. This is what we try to look for ultrasound at 3 months. At this point, again, let me remind you that all ultrasound markers, the same wavelength, all biochemical markers will have its own negative and its own positive likelihood ratio. Now, because now we have understood that every lady has got its own risk a priori, but the final risk is going to be calculated on the basis of risk a priori. That has to be divided by risk factor derived from screening of the various tests, whether it is ultrasound or by biochemistry, by its own positive likelihood ratio or negative likelihood ratio. The meaning is simple, that if I have evaluated in the first trimester, I will take risk a priori, and then if I have evaluated nuchal, it can be LR1 could be nuchal, LR2 maybe nasal bone, LR3 maybe ductus venosus, and then if I have evaluated in the second trimester another 8 ultrasound markers, then I will add on this likelihood ratio, go on and on and on, and eventually I can come to a final risk, what exactly that lady, that fetus carries the risk for Down syndrome. So as I told you, there are 2 points which we need to understand, is detection rate and the false positive rate, and they are the one that, because if I apply X test, what is the capacity of that test to detect that disease? That is what is detection rate. And a false positive rate, the meaning is how much amount of false alarm that test is going to generate after the screening process, because we are dealing with a screening tool, and this is what I have already told you. So because we are dealing with screening tool, not diagnostic, for me, any test which can detect up to 95% of detection rate with a 1% of false positive rate, that's an ideal test. Around 90% detection and a 3% is good enough in our Indian scenario. But any test which has got a below 80% of the detection rate or 5% false positive rate, that I don't consider as a good test. And I think if we set at this rate, 90% detection rate with 3% of false positive rate, that is good for developing countries like India. And this is what we will put it across. This is a concept of screening. Again, the concept of screening includes all biochemical markers. If I want to filter this, if it goes through a filter, then there are few diseases few Down syndrome screening, which I can evaluate after X test, but there are going to be some cases which are going to go away, which I may not be able to detect. And so that is the reason they are all screening tests. They are not definitive tests, and we have to learn what actually the screening test is all about. This slide will tell you about the game of risk cutoff and detection rate. So let us understand this trisomy 21. If I today in our clinic, we consider as 1:100 as cutoff rate. If I use 1 in 100, I'll be able to detect 90%. If I put it 1 in say 250, that is here, I will be able to detect 94% if I apply this test. But here there are more chances. I will be doing more extra. I'll be able to diagnose 3% more, but I will be also increasing the invasive procedures. They will create extra false alarm. So usually across the board, internationally, 1:100 is accepted as cutoff range, not 1:250. And at Paras, we accept 1:100, not 1:250, because so many labs biochemical markers takes as 1:250 as a cutoff. And I can request all of you to ask the lab to put it at 1:100, so that you will end up in less and less invasive, and more kind of your diagnosis of the disease. So this is what exactly I mean, the game of cutoff and detection rate. Now, prenatal test, as I told you, the screening, ultrasound, as well as the biochemical markers. If you really look at all biochemical markers, free beta HCG, PAPA, PLGF, alpha fetoprotein, HCG, E3, AFP inhibin, all are proteins. This is all ultrasound markers. Ultrasound marker is the visualization or the anatomy. So I call all ultrasound markers as a phenotypic expression of aneuploidy fetus, and all proteins, because protein synthesis need a gene to synthesize, and because every protein needs a gene to synthesize, I call all expression of abnormal protein is a genotypic expression. And so we have got phenotypic expression, that's by ultrasound, or genotypic expression of aneuploidy fetus, that is by all biochemical markers. Use anything which you have. If you have got brilliant phenotypic expression, you should utilize all your that ultrasound markers. If you want to take help of genotypic, it's again going to be your choice, because if patient can afford, you can always take a help of them, or else you can rely on phenotypic expression of the fetus. So my target is to hit 90% of the detection rate with 3% false positive rate. So let us try and take, you can utilize any of them, phenotypic or genotypic expression. Reach, your dart has to hit the center, detect 90% of them, and detect 90% of the chromosomal defect. And there are many tests available, and let us try and understand what these biochemical markers are going to tell you about. An ultrasound is also going to tell you about. I will go for only the test here, because they only give me about 90%. So that's the reason I will utilize only these 5 possible tests available to me. You need good machine, FMF certification, software to report, because you will need it. First time as a soft markers, as I told you, the best thing is nuchal. Nuchal is nothing. Good CRL, zoom this portion, and you will find the good brilliant your nuchal translucency, which is going to be here, nasal bone, and lot many frontomaxillary facial angle. You can see IT, lot many ultrasound markers can be seen, soft marker by single one thing, and you can take help of this. The basic idea is to look for these excess fluid in a Down syndrome autopsy picture. This is where we are interested in looking for nuchal. Now, how effective nuchal is. Nuchal is high in all major chromosomal defect, and nuchal is really good, and this will guide you how increased nuchal will give you. If increased nuchal associated with abnormal karyotype, you have reached your diagnosis. But if your new chromosomes are normal after increased NT, this could be your possibilities. Higher are the chances of chromosomal defect, more chances of fetal death, more chances of fetal major malformations, but still there are chances of good and alive well babies. So increased nuchal needs further investigation, nothing more than that. So you need to understand that kind of stuff. Again, fetal nasal bone, that is again one of the good criteria to identify aneuploidy. This is what the hypoplastic nasal bone is equivalent to your absent nasal bone. It has got its own association with, it can be present in a normal hypoplastic nasal bone, can be also associated with normal pregnancy, but that is one of the important factors. Ductus venosus reversal or increased PI tells you about a possibility of Down syndrome. And the thumb rule about normal ductus is, this is going to be 1 is going to be normal, but 1 plus or minus 0.1 is normal. Anything above 1.25 is abnormal. If you can remember this, any DV more than 1.25 is abnormal, and there are chances of abnormal ultrasound finding. Tricuspid regurgitation, again, also one of the ultrasound marker. So all in all, we have got some brilliant ultrasound markers: nuchal, nasal bone, ductus, tricuspid regurgitation, and this will be associated with abnormal ultrasound markers. Now, double marker test. Biochemical markers using first trimester screening. It has to be done between 10 to 13 with 6 days. Few thumb rules: please provide LMP, height, weight to calculate body mass index, whether she had history of trisomy 21. Correct CRL is mandatory, necessary. If you have done NT, if you are certified for NT, then and then supply NT to them. Otherwise, if you are not certified, don't supply to a, don't give information about NT. Otherwise, they will be creating a false report, because you are the NT may not be correct, and you may come out with wrong results. So these are important findings. But let us understand how the what is pregnancy associated plasma protein A, and what's the importance of each of the marker. The PAP A, it has got, it's a large glycoprotein, and it has, if you use alone, it has got detection rate of only 52% with a high false positive, but it is reduced by 0.2 mom with the Down syndrome. You need to understand that low PAPA will be associated with all chromosomal anomalies, and it indicates poor fetal outcome and probably obstetric complications. So if you know how to read low PAPA, anything below 4, 0.4 PAPA, please be careful. That lady may develop preeclampsia, hypertension, growth restriction, not only Down syndrome. So be careful. Low PAPA is not only Down syndrome, but also indicative of possible poor outcome and obstetric complication. High PAPA has got no value. The same thing is with the free beta HCG. Never ever calculate total HCG in the first trimester. It's only free beta HCG. Only beta HCG has got detection only 42%, high false positive rate, but it is also a placental glycoprotein. Synthesis is from placenta, and total complete is effective in second trimester. Make sure the high HCG is with the Down syndrome or paternally derived triploidy, and it can also possibly suggest the poor placental outcome. So the smaller is the placenta, higher is going to be the free beta HCG. So make sure that you read the mom values. Low beta HCG has a maternal possible triploidy, is there in trisomy 13 and 18, and also going to be suggestive poor outcome. But when you are using a PAPA dual marker, make sure that if you are sending the sample quite in a far away from your place to lab, serum is separated. Otherwise, the whole blood will have altered result. And particularly the PAP-A, if the temperature, we are living in a hot climate, so if the temperature is maintained at 5 degrees of the sample, it will not have any side effect. But if it is stored in a dry, hot place, the PAP-A is going to be altered every day. And if the temperature is 40 degrees, which is now here in Ahmedabad, the every day it increases by 500 to wrong report. So make sure that there are a lot of problems with the hot climate in India, and make sure that you are doing the biochemical markers appropriately. Multifetal pregnancy, we will discuss that part. just after some time. So transportation in separated serum with a cold chain maintained. If you can get your dual marker, then and then only rely on these dual markers. If you can't get it done, like maintaining a cold chain as well as sending a whole blood, you will have a possibility of altered outcome. So make sure that you are doing with that. This is what a first trimester dual marker. Nuchal increases 2.67 mom, beta HCG 2.15, and PAPE is going to be 0.15 mom with the trisomy 21, and detection is going to be 90%. This is the combination. Trisomy 18, 13, nuchal is always high. Beta HCG may be high, low, low. But look at PAPE, low, 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 always low. It gives you clear idea that nuchal is going to be more and PAPE is going to be less if it follows these combination. This is a multiple combination of all biochemical markers. But if I have to go for first trimester, make sure that it follows with this and it gives you clear idea. Two rules: nuchal is going to be high in all and PAPE is going to be low in all fetuses. So whenever you are dealing with this situation, you should think about a possibility of chromosomal defect and be very, very, very careful about those stuff. Importance of nuchal in combined test. If you do it with nuchal and without nuchal, it can tell you that if you do it with nuchal, gestational age increases. With nuchal also is going to be around 80%. Without NT, it will have no value. So don't do it only biochemical markers. I've seen lot of our colleagues going for double marker test at 12 weeks alone without doing NT. No, because only biochemical markers without NT has got around 50 to 60% detection only, which is pathetic. You will never be able to diagnose more than 40% of the Down syndrome and doing only biochemical markers without NT. And if you can do NT, you can do nasal bone, and so you may not require further biochemical markers at all if you are settled with 90% of the detection rate. So make sure of utilizing appropriate ultrasound markers and if needed biochemical markers. These are the 2015 data by our Cochrane database of systematic review. All data which were evaluated by 5% false positive rate, and if you really go for all sorts of different combination, what we could find it out that the moment you have got PAPE, free beta HCG, you will have 68% only detection if you go for only biochemical markers. So this is again not good. They are not my data. This is Cochrane review. And here for each test strategy which are shown on horizon of axis A. So this is about using only biochemical markers. So it gives you clear message. Don't use biochemical markers alone. Utilize with ultrasound, and if you can do appropriate ultrasound, eventually you will feel that you need biochemical markers in few number of cases. So this is what will give you a crystal clear idea. So combined screening, that this is the word which you must have heard many times. It tells you about CRL, nuchal translucency, and biochemical markers. So they use only nuchal, heart rate, free beta HCG, and PAPE. They take only 4 things into consideration, and they calculate the risk. So, and at the end of the day, they will say that the background risk was 1 out of 3 to 1, but now the background risk is 1 out of 2, 8, 6, 7 if they all are falling within normal range. So here it is not, don't read the value, read the mom values. This is 0.7 mom, so it is little bit 30% lower than normal. PAPE is also 0.74, that is also 25% lesser than normal median range. So it gives you the risk is like this, and it will give, eventually it will give you this is screen negative. Don't only read the screen negative or positive, try and understand these mom value, and that will give you a complete clue. Accuracy of first trimester for 21, 18, and 13. This is 2017 data from Kipros, that they have evaluated more than 100,000, and what they could find out that the combined test will give you 90% for trisomy 21. Trisomy 13 and 18 anyhow I'll be able to detect by ultrasound, but it gives you 90% for trisomy 21. So it gives you trisomy 21 is 90%. Anything at a false positive rate of 4%. So if I put it at 3%, the detection still is going to go down. Internationally, 3% is acceptable. If I put it the same data at from 4 to 3, it will still be below 90%. One new concept of two-stage first-time is a screening for trisomy 21. Again, a Kipros group by Oliver Kagan and Kipros Nicolaitis. They have screened more than 20,000 patients by this, and they have applied a contingent policy in first trimester screening. What they do, the contingent policy, let me explain what it is. The contingent policy means we will do first screening by only ultrasound, that is by nuchal, nasal bone, and ductus venosus, and if required tricuspid regurgitation. And if after putting everything into the soft marker into the software, if it tells me the risk is low risk, more than 1:1000, less than 1:1000, we ask her to go home. Counseling, nothing special investigation is needed. A lady who is more than 1:100 risk, straight away invasive testing. And a lady who is between 1:100 to 1:1000, they are the ones where they had offered biochemical markers, and see what is the result. So it is that stage. This is the 5 groups, only ultrasound with dual marker. Here the only NT and biochemical markers. Here the age, nuchal, and nasal bone, and here only first biochemical markers, and then SOS ultrasound. The detection rate at everything were compared at 3% false positive, and the detection rates are in front of you. It tells you the highest detection is by nuchal and ductus venosus and SOS biochemistry. The only 14 or 15% of the cases where you will need biochemical markers, and that's the reason if you do your maternal age, nuchal, nasal bone, ductus, and if SOS biochemical markers, and if needed biochemical markers, in that case, which will be required in 20% of the cases which are going to fall in the risk between 1:100 to 1:1000. So your detection is going to be 96% with only 2.7% false positive. Far better than doing only combined test. Only thing is you have to learn a nuchal, which you already are doing. You have to look for just nasal bone and learn about ductus venosus. You have got a machine, you know nuchal. If you can know nuchal, nasal bone is going to be there. Ductus you have to learn. If you learn once, it's for lifetime. You can have better diagnosis, less expenses, and that is what at the end we clinician we have to do. Routine biochemical screening has to be replaced by good ultrasound screening, and maternal biochemistry only in 20%. Your detection is going to be 96%. So that is what we recommend at Paras, and this is what is going to be there. So let me skip some of the slides, and some of the new markers, PLGF and alpha fetoprotein, they have added here in the first trimester. But this is PLGF and alpha fetoprotein. They are costing more than 5,000 rupees, but that will just add a couple of percentage from 87 to 94%, if at all you are doing adding PLGF and alpha fetoprotein. 5,000 rupees is, I put it quite a lot of expensive thing, because government pays you just 4,000 rupees for carrying out delivery. There are some government running some schemes where they pay you just 4,000 or 5,000 rupees for doing, whether you do cesarean section or whether you do deliveries. And why to pay 5,000 rupees for PLGF and alpha fetoprotein in first trimester just to add couple of percent of possible trisomies. So I will still stick to my guns. I'll ask you to go for better ultrasound, good ultrasound. Even in UK National Screening Committee, they recommend cutoff is 1:100, not 1:250. And so make sure that you change. If at all you are leading to 1:100, that's fantastic. Otherwise, you from 1 to 250, you should go to 1:100. So make sure that at the end of the nuchal scan, you will have some good kind of risk assessment calculation, which was background risk was 1:1000. It has gone to 1:20,000. If the without biochemical markers, if the risk has gone down to 20,000, I don't need further screening. So still, because even if I have added biochemical markers here, I have done biochemical markers which are mentioned here, the risk never changes, because the software which is fetal medicine, this is fetal medicine foundation software, it has got a truncation capacity. That truncation capacity means to alter the risk. The ultrasound can alter the risk by 50 times. If it is bad, it can increase the risk by 50 times. Biochemical markers, if they are bad, they will be able to change the risk by 20 times. So more is the capacity, better is the factor for disease or diagnosis. That's the reason, if you have got a good ultrasound machine, if you can learn ultrasound better, you will be able to produce far more better accurate result with less and less expenses, and better utilizing your capacity as well as better utilization of your ultrasound machines. So adding biochemical markers with ultrasound doesn't make any difference. So in low risk population, high risk, anyhow, high risk is there. I'm skipping some of the slides here because it will tell you about some of the biochemical markers, and not biochemical markers, but only ultrasound markers. Advanced age is something which is going to be different. There even minor change in nuchal is also going to be telling you about some of the differences. Now we have learned dual marker. Let us understand NIPT first, then we'll go to quadruple marker. NIPT is non-invasive testing for circulating fetal DNA in maternal blood from prenatal diagnosis for common aneuploidy. Now, let us understand the basic concepts. In cell-free fetal DNA, these cell-free fetal DNA originates from the placental trophoblast, because that cellular lining is in contact with the. So those cells which are dead here, a placental trophoblast, they will be thrown into the maternal circulation, and because maternal circulation will identify them as a foreign cell or foreign protein, this is going to destroy that cell. Nucleus is exposed, nucleus is also destroyed, the chromosomes are exposed, and because chromosomes are also exposed, they also will be destroyed by the fetal the maternal body, and they are converted into the small pieces. Now these fragmented DNA, when you extract from the maternal blood, it has got a different property than the maternal DNA itself. The fragmented DNA are almost around 200 base pair in length if it is fetal in origin, but they are significantly smaller than the maternal fragments. Maternal fragments are more than 400 to 600 base pairs. So a maternal blood is taken. From there, the fragments which are around 200 base pair, they are separated, and because they are separated, and then they are run as a massive parallel sequencing with the normal the human genome, and they try and match these fetal DNA with the normal human genome. If there is one extra circulating this fragmented DNA of trisomy 21, 13 or 18, this is going to pick up extra into the control panel, and that is how they will tell you about the possibility of the extra chromosome because here we are detecting a fragmented DNA, the chances of diagnosis of the disease is going to be far more better. And that this is typically known as targeted sequencing. And these targeted sequencing is the every fragment is going to be running parallel to the normal human genome, and it will be probably give you more than 99.12% detection with only 0.12% of false positive rate. So it has got a very the highest possible detection and the lowest possible false positive rate. Is the best test available for detection of trisomy 13, N20, 21, and 18, and with the sum of the sex employees. It has got, then why not to be applied to everyone? Because it has got a couple of disadvantages. Now it had prohibitive cost. It started from 32,000, then gone to 24,000, 18,000, 12,000, and now 7,000. You can get your NIPT, self-fetal DNA, done in NIPT by NIPT. So the concept, it has become a game changer. Where we recommend NIPT is those falling into intermediate group after a contingent policy of screening. I'll explain you what it is. Those who want more precise diagnosis, those who has got money willing to spend, they want to evaluate the best possible thing, they can go for NIPT with a precious pregnancy like advanced maternal age, after ART pregnancy, or those who can afford, those who want to spend and get the best result, they should be submitted for NIPT. There are few problems also. When the fetal fragments are less, the chances of chromosomal defect increases. When somebody asks you to repeat because of insufficient cell-free fetal DNA in quantum, think twice. Then there is also one of the indication you may think about going for invasive testing rather than repeating them there. So PARA's protocol for aneuploidy here is whether it's a first trimester, estimate your risk for trisomy 21 by NT, nasal bone and ductus. If it is high risk 1:100 or more, we go for CVS. Low risk 1:1000 or less risk, no further screening is required. Intermediate risk between 1:100 to 1:1000, we go for cell-free fetal DNA. Those who are negative, nothing is to be done. Those who are positive, it has to be confirmed by CVS, and that's how we follow your first trimester screening in contingent policy. Ultrasound and cell-free fetal DNA, we don't utilize biochemical markers in all pregnancy, because this is one cost effectiveness. It's 20% cheaper. This is economics. I'm Gujarati, and we will always think about the cost effectiveness of any protocol. So this is one slide I have put it across. You may go through, but still because of the lack of time, I'm just going hurriedly for second trimester screening. Second trimester screening by biochemical markers, that is typical quadruple marker. Triple marker is out of date. Don't think about triple marker anytime. It has to be AFP, beta HCG estriol, that is E3, and inhibin. Because it has got fetal liver or placental in origin, they all are. There are quite a historically, let me put it across, that maternal screening testing, as I told you, between 10 to 13 weeks or 16 to 20 weeks, it has to be done, not before or after. Never investigate any lady between 14 to 16 weeks, because it gives you such a high false positive rate about trisomy, and you are going to end up in a lot many problems. So as I told you, triple or quadruple marker, I still wish the alpha fetoprotein, we have discussed about beta HCG PAPE, the same thing, let me put it across, the alpha fetoprotein. Again, it's a glycoprotein, and unaffected will have this, but open spina bifida and acrania, this is going to go up in mom values. So make sure that higher is the value, you will have more is associated also CNS, open neural tube defect. Abnormal alpha fetoprotein, it is raised. If it is raised, check out for the gestational age, whether your gestational age is correct or not. Rule out multifetal pregnancy, rule out single fetal demise, rule out neural tube defect, rule out there is no previous fetal reductions. They all can increase alpha fetoprotein. If it is very low alpha fetoprotein, I have also mentioned some of the abnormalities where alpha fetoprotein can go wrong. Other causes of alpha fetoprotein, I have just enumerated. I have just enumerated everything. Unconjugated estriol, that is UE3. UE3 by also produced by liver, fetal adrenal cortex, also from the placenta. But there are few stuff. Extremely low E3 is important. Any value less than 0.2 mom of E3 will have possibility of these many syndromes. So don't look at screen negative, screen positive, look at mom values. You will be able to identify so many of the possible abnormalities of the fetus, not only aneuploidy. So HCG, again, I think we have also already discussed about inhibin A. It has got detection rate of only 62% with a false positive rate of 5.2%. It increases by 2.6 mom. So it is going to increase by 2.6 times than the normal value. Inhibin A has got two chains, alpha and beta. But I'm not going to into structures because right now we are just running short of time. So, and this is one typical graph in the second trimester. The alpha fetoprotein is going to be 0.74 mom. This is Stross trial. That means alpha fetoprotein is going to be 25% less than normal. E3 is going to be 30% less than normal. HCG will be almost 1.9 times than the normal, and inhibin A is going to be almost double the inhibin A. So this is a median mom value. So these two are going to be reduced. These two are going to be increased when you are dealing with quadruple marker test. So again, the detection rate, if you are using quadruple marker, somebody says that it can go up to 81% if you are using second trimester biochemical markers, but at a rate of 5% false positive. The moment I keep it here 3%, it will drop down to around 71% or even lesser than that. So these two has got, this is 3%. Again, one study has got shown you 67 to 74%. Here I have put it across the value of quadruple marker test between 16 to 21. But look at the values which are changing. E3 in some of the values are going to be some varied mom. Here HCG is high, low, 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 again median. So nothing is following the rule. So you have to understand the mom value with each of the biochemical markers. And that's the reason you have to be very careful by evaluation of all your moms. These are the factors which may affect the serum markers. Just one thing about stepwise sequential screening. 2-stage risk assessment to be done at each stage. Result is given after combined screening. Then if screen negative, they can offer you quadruple screening. First trimester risk is used when calculation of the finals risk for you calculate your next screening. This is what your stepwise sequential screening is. And contingent sequential screening is what? You don't disclose your first trimester result to the couple. You ask her to come down at second trimester quadruple screening also, and then you do it. That's where you do it a contingent sequential screening. High risk, one is 30 CV straight, low risk 1000 nothing, no further test. Intermediate risk quadruple screening, and then you give her the further testing if required. Multifetal pregnancy, I'll tell you only one thing. When you are dealing with multifetal pregnancy, one thing is sure, then of course master key is going to be the identifying the monochronic or dichorionic twin. Ultrasound is playing crucial thing, because more than triplet or more than triplet biochemical markers are useless. Nobody has evaluated the role of biochemical markers. So don't do any biochemical markers in triplets. Only ultrasound will help you in multifetal pregnancy in triplets. Now, role of biochemical markers, let me tell you one thing. It will have, if you fix up a detection rate of 80%, then singleton pregnancy will have 5% false positive rate. Dichorionic twin will have 10% and monochorionic will have 13%. So this is the value, and that is the change which is going to happen after your twin pregnancy. So the detection rate falls, or the false positive rate goes up whenever you are utilizing them. Cell-free fetal DNA, lower is going to be the fetal fraction with multi-fetal twin, higher is the failure rate. Be careful about also asking in an obese, post IVF, obese and multi-fetal pregnancy, your detection rate for trisomies, they are going to be around in 90%. So don't expect 99% with an obese, multi-fetal pregnancy and post IVF conception. So these are few key points about the screening in aneuploidy in multi-fetal pregnancy. And now at the end, whether it's a first trimester or second trimester pregnancy, let me tell you again, this is what we follow in first trimester. And in second trimester, we do all of ultrasound, maternal age and all fetal markers. Again, we follow the same 1:100, 1:1000, nothing. 1:100 or more, we offer them amniocentesis. Between 1:100 to 1:1000, we offer them cell-free fetal DNA. If negative, we do nothing, and positive, we go for what we have already discussed about. Messages are clear. Dual marker between 11 to 13 plus 6 weeks, and quadruple marker between 16 to 11 weeks only. Go for ultrasound first, then utilize biochemical markers only. You will need only in 20%. You may not need in more than 20% to do biochemical markers. Read mom value in report, not only the positive or negative. That will give you lot many clues. Triple marker should never be done. Biochemical markers between 14 and 16 weeks will have high false positive results. NIPT is cheap, 7,000 rupees. It's always better to use in case of dilemma. That's the reason your biochemical markers, I would put it as a dying modality. This is going to die in near future because still NIPT is going to go cheaper, and it will take toll of these biochemical markers. That's what I can predict. Best time and method for aneuploidy screening is 12-week anti-nasal burn, ductus venosus, which will give you 96% and 3% false positive rate. For better detection of aneuploidy, do better screening, good scan, appropriate investigation, and that will give you idea, and spread this idea, help our patient, and that's how we have to go for it for aneuploidy screening. Thank you very much for your patient hearing.
Thank you so much, sir, for your insightful lecture. Now we'll go ahead and take some questions now. There are around 70 odd questions, sir, but due to time constraint, we'll be able to address only few questions. So apologies on my end. So first question from Dr. Tejas Tamhane. He's asking, if the patient is having spotting or active bleeding, will it affect screening results of FTS or quad?
Hello, Abhijit.
Sir. Hello. There is one question
Any
from
questions?
Dr. Tejas Tamhane. Hello, can you hear me, sir? Can you hear me, sir? Can you hear me, sir? Hello? 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 विजय?
हाँ, मैं आपको सुन पा रहा हूँ.
हेलो.
हाँ सर, आपको मैं क्वेश्चन आंसर ले रहा हूँ सर, आपको आवाज नहीं आ रहा था.
इसीलिए मेरे को भी आवाज नहीं आ रहा है, सो आई डोंट नो.
ओके सर, मैं हेलो.
हेलो.
हाँ सर, आ रहा है अभी आवाज? हेलो.
गौरव भाई, आवाज नहीं आ रही, जरा चेक करिए ना.
हेलो.
हाँ सर.
कैन यू सी माय स्क्रीन? कैन यू स्क्रीन सी?
हाँ, I can see you, sir.
Okay, fair enough.
Okay. Hello.
मालवी साहब फोन पे पूछ रहे हो ना क्वेश्चन?
Are there any questions?
हाँ. Yes, sir. Yes, sir. Sir, there is one question from Dr. Tejas Tamhane. He is asking, if the patient is having spotting or active bleeding, will it affect the screening of FTS or quad?
Yes, it will. This is going to bleeding will have a effect on beta HCG level. So be careful about asking for markers at that time.
Yes. Then there is next question from Dr. Vartika. She is asking role of NIPT in second trimester.
Definite, there is a role of NIPT. Whenever you feel like that your ultrasound markers are showing something and patient needs further investigation and they don't want invasive testing, or if you feel that it's an intermediate risk where I do not want to do invasive testing, you can definitely take help of NIPT, because NIPT will give you only about 8 days to come. The turnaround time is 8 days and costing 7,000 rupees. You can always get it done even in the second trimester till the end of 22nd week. So at 21st week, 6 days, you can get it done. After that, there are no valid data available for use of trisomy, this NIPT for trisomy 21. Some labs does it till 24 week on experimental basis.
Then there is a question, sir, from Ruchika Sood, Dr. Ruchika Sood. She is asking, can quad marker be done in twins and what is the sensitivity?
The quad marker in twin, you can do it. Only thing is the sensitivity is not more than 70%. It is falling below even less than 70%.
Okay, sir. Dr. Shah Nilesh Hasmukh Rai is asking, up to which gestational age NIPT can be suggested?
21 weeks, 6 days.
You can discuss both directly through Zoom call. Your both audio video is perfectly coming.
Hello,
Yes.
sir. Dr. Shashikant Vasant Vyawhal is asking, which platform is better for double marker?
There are multiple platforms. One is Roche, another is PerkinElmer are using. There are so many other platforms which are available. The third one is Immunoemulance. That is the most basic one. The false positive rate goes up the more and more basic version you are using. There are some labs which gives you report on Prisca software, which gives you higher the false positive. So the Fetal Medicine Foundation recommended platforms, if you use, it will be standardized. You have got a standardized reporting available whenever you want to utilize.
Okay.
So Roche or PerkinElmer.
Sir, Dr. Madhu is asking, sir, please tell us about approach to non-ossified nasal bone.
Non-ossified nasal bone is simple. If you are dealing with the first trimester, between 11 to 13 week, your software you have to feed the information that CRL is X, nuchal is Y, nasal bone is absent, ductus venosus is Z. The software is going to calculate the risk for you, and if the risk is less than 1:1000, you don't do anything. If the risk is more than 1:100, go for invasive testing. Risk is 100 to 1000, you can give the option to the couple to go for either invasive, or you can ask her to go for NIPT. In second trimester, you know the age of the mother. Because of your knowledge of the age, from risk a priori table, you will be getting a risk a priori. And unossified nasal bone will increase the risk minimum by 6.6 times. So let us take example. A 25-year-old lady who has got risk of 1 in 800 as a risk a priori, if she has got unossified nasal bone only as soft marker, these 800 has to be divided by 6.6. This will come is to 1:30 around. So you have to counsel that lady that you have got chance of having Down syndrome 1 out of 130. So a lady like you, if I get 130 lady, one will have Down syndrome. Or in simple word, 1 out of 130 is around 0.9%. In that case, you can counsel that 99.1% the fetus is maybe chromosomally normal, but there are 0.9% chances that the fetus may have trisomy 21. If you want to know whether your fetus is in 0.9% or 99.1%, we may advise you further investigation by NIPT or CVS or amnio. That's how your counseling has to be. And every NIPT, because it has got advantages of being non-invasive, but it has got limitation of detection of 99%. Invasive, 100% diagnostic, but it carries a possible risk of miscarriage after the procedure. So both things you have to explain, and let that mother, let that couple choose. That's how you have to go forward. But every discussion has to be put it on consulting paper and counsel them like that. Let them take decision.
Sir, next question is from Dr. Ali Jiwani. He is asking any role of quadruple test in first trimester.
0.
Then, sir, Dr. Ritu Punhani is asking what is the percentage of cell-free DNA needed to infer?
It is minimum 4%. Some of the labs has come out with 2%, but lesser the fragments, more are the false positive rate, and the wrong reports will be there. Ideally, around 8 to 10% has to be there minimum.
Yes, sir. Then Dr. Tejas is asking any specific indications for which extended FTS should be advised?
What do you mean by extended FTS? Can you ask them?
Sir, I cannot contact him right now. Okay, sir, I will take next question.
Let me answer this.
Yes, sir.
Every examination is always extended. You cannot say that it was a basic examination, I have not done extended examination. Every examination, whichever you do, always has to be complete and extended examination. Best you can do, should be offered always.
Then, sir, next question is from Dr. Sarda Vemparalla. She is asking, sometimes we see isolated reports of high beta HCG. What does it indicate?
See, as I told you, there I have already shown in my slide that high beta HCG has got quite a lot of possibility of poor outcome. It may tells you about the smallness of the placenta, future development of growth restriction also will be there. Hello.
Dr. Pavitra Dharmapuri is asking, sir, if we follow your protocol for FTS without serum biochemistry, for whom is serum biochemistry advised, as you said in 20% may need it?
As I told you, that if I put my bone and ductus, the software will give me the risk. If the risk is below 1:1000, I will not advise them any further biochemical markers. The risk is between 1:100 into bracket high risk. I will advise all of them invasive testing. If the risk is between 1:100 to 1:1000, they are the ones I will still advocate them cell-free fetal DNA if they can afford 7,000 rupees. If they can afford only 2,000 rupees, then I will advise them to go for dual marker.
Then, sir, next question is from Dr. Chitra Shankar. She is asking, NIPT is apparently not diagnostic. So how do you counsel your patients?
NIPT is not diagnostic. If the couple wants 100% diagnostic, I have no option but to offer them invasive testing.
Okay.
I would like to add one thing on the previous question. Severe growth restriction or preeclampsia or abruptio placenta, I will go for PAPE and PLGF if required in the previous question, if you want to add into that.
Okay, sir. Then Dr. Akila Srigauri is asking, is injection SCG can affect aneuploidy screening?
Yes, it can affect, the level is going to rise temporarily. So never ever do your invasive, dual marker within 2 or 3 days of giving HCG.
Then Dr. Tejas is asking, if the patient has done quad test at 15 weeks instead of beyond 16 weeks, and if it shows high risk, should we advise repeat quad or should we go with NIPT, DIRCT testing?
I will give them both the choice. I will ask them to come at 18 week. I will do my scanning. I will evaluate all soft markers, and I'll get a second quadruple marker test done. I will combine everything and generate a report. If the risk is less than 1:1000, I may not need anything.
So the last question of the day from Dr. J. Panigrahi. He's asking, biochemical test only shows 1 in 200, no proper NT, but my USG screening, only second trimester, is 1 in 1500. How to counsel and how to approach?
See, the 1 in 1500 is, you are already talking about low risk pregnancy. 1 in 1500 means low risk. You have to just counsel that 1 out of 1500. This is less than 0.1%. And because it is less than 0.1%, we do not go for further investigation by invasive testing, because invasive testing will have more risk of loss of pregnancy than 0.1%. Okay. Now, if you have got 1 in 200, at that point of time, you should have discussed with the couple that you have got 0.5% chances of aneuploidy. Because if you want further investigation, you can go for further investigation.
Thank you, sir. Thank you for such an insightful lecture. We'll go ahead, sir. Thank you for sharing your expertise on this very important topic in lucid way. I'm sure audience has gained a lot of insights.
Thank you very much.
I'd like to thank all our participants for taking out their time for this webinar. I'll also like to thank our BU head, Mr. DP Satpathy sir, and divisional head, Mr. Manish Shah sir, for making this event possible. Have a nice day ahead. Thank you, sir. Thank you so much.
Thank you.